Where'd it go?
Hello.
How's it going?
Hello, guys.
How's it going? Happy New Year.
New
Happy
Year.
New Year.
Is everybody doing?
Doing good. Very good.
Yeah, good.
Officially in the third trimester.
Yay. Okay. Wait, when's your due date again?
End of March.
Oh gosh, wow, that seems
Yeah,
like that's it's happening.
I know.
Yeah.
It's
Yeah.
crazy. Yesterday I went to the doctor, we had the glucose test, and she's like, "Oh, you're measuring 31 weeks." I'm at 28 weeks, and I'm like, "Oh, geez, I feel huge already."
Gosh, just means your babe is healthy. That's all.
Yeah, no, thankfully everything's good. We have an ultrasound end of the month, so there we'll get more of an idea if it's like amniotic fluid or if it's the baby or who knows. We'll see.
Thanks.
But
Rest. Don't stress yourself out.
no, I feel very calm with everything, honestly. Maybe a little bit too calm. But but no, excited about it all.
That's good. Yeah, it's get ready for lots of not sleeping.
Thanks.
You'll get used to it. And then it just stops one day and then they grow up and then they don't need you anymore. So enjoy it.
Oh, geez. Yeah,
Yeah, then it
no.
just keeps changing. It just change once you get used to it, it changes, and then it changes, and then
They need
it's
you
yeah.
in different ways each time.
Yeah, it's wild. It's a wild ride.
Yeah, I can imagine. Justin, Charlotte's not going to be joining us. I don't believe she's not feeling very well.
Okay. I'm going to do a presentation on just like some inflammation markers on our testing, kind of talk to that, and then we'll do a Q&A. I think we got like 6 people here, so I'll start to load them in. Hello, everybody. Happy New Year. Hope everybody had a great holiday, and thanks for joining the Hormone Happy Hour. We have some lots of new clients joining around this time of the year, so I wanted to do a slide on some of our testing, specifically some of our inflammation markers, and those are some of the things I like to cover in depth. I know we do a lot of emphasis on hormones, but also wanted to talk about the importance of these. So yeah, I hope everybody's having a great start to their week. I know a lot of us are just returning back to work and getting back into the swing of things. So I'm grateful for everybody joining. And yeah, we'll get in here and cover these slides and then we'll do a Q&A and answer some questions more at the end. So key inflammation markers we test. These markers explain why fat loss, hormones, energy stall, even when basic labs look normal. Inflammation is a common blocker, so we'll kind of talk about some of the our specific testings and why we do them. So let's see. Something we'll see on your lab work is something called a C-reactive protein. And what does it tell you? It's systemic whole body inflammation. So why does it matter? Why are we checking C-reactive protein? A lot of times it can put you at risk for cardiovascular disease. A lot of times it's in conjunction with other markers like insulin resistance. And then when we get into the whole inflammation conversation, mitochondria function is something we want to consider as well. So your cells can't work efficiently if there's a lot of inflammation. Um, or the US clients and Canadian clients, the CRP will be gauged from a 0 to 3. So really idea here is to have this less than 1. 1 to 3 shows that there's some low-grade inflammation, and then sometimes I see these as high as like 10 or 12. So different areas of the body can drive some of this increase in C-reactive protein, and we'll cover some of these other markers. But yeah, I think, if CRP is elevated, fat loss becomes difficult, specifically holding fluid in certain areas. A lot of times CRP is high with insulin resistance, and insulin resistance is a big thing that can slow down the ability to lose body fat. So, it's not just your testosterone, estrogen, progesterone. We really want to look at a whole picture. Ferritin is another hormone, or I'm sorry, another inflammation marker that we look at. And ferritin is iron storage. So a lot of times, depending on the context, if we have somebody who's coming into program and maybe they have a heavy menstrual cycle or frequent bleeds, ferritin can be low. It's common with low iron as well, since it's iron storage. Sometimes in the postmenopausal scenario, ferritin can elevate pretty significantly. So when we look at high levels of ferritin, it is a chronic inflammatory issue. It can drive up things like liver stress, um, maybe some components with insulin resistance, and then infection. But the interesting thing with ferritin, since it's a pro-storage hormone, that excess ferritin can store in the liver, that could store in kidneys, brain, heart. So we don't know exactly where that's coming from when we just pull it simply in blood, but we just know the system is potentially um, overridden by excess ferritin, and we want to look at other labs to get an idea of potentially how we can improve that. I've have someone on this call. We were able to reduce her ferritin within 8 or 10 weeks of doing some liver detoxification and some GI stuff. So, being able to control this is really dependent on where and how severe it is, but it's something that you can improve. Um, Next is the fasting insulin. So, what does it tell you? It's metabolic inflammation. Why does it matter? So, chronically high insulin is pro-inflammatory. So, that ties back with that C-reactive protein. Insulin is a pro-storage hormone. So, if your insulin is really high, your body's going to have a hard time shifting to fat oxidation and being able to burn body fat. Um, so suppressing fat oxidation. The range for US and Canadian clients is 2 to 24. So it's this gigantic range. Really, I would say having a fasting insulin 12 hours without food should be less than 8. The lower the number, I would say is better. There's some caveats. We don't want it too low, but I would say, 2.8 to 8 is ideal for most people. Um, when we start getting upwards to 10 is really when I'm starting to worry about that. What you want to take in consideration with this elevation of insulin is going to be some of the other markers like your A1C. And that's something that's really common here in the US. We look at a hemoglobin A1C. What is that? That is a red sugar molecule on the red blood cell. So long-term glucose exposure creates glycation stress. So glycation damages the mitochondria. It stiffens tissues like the cardiovascular system. So when I see high A1C, there may be some metabolic disturbances, but we also want to look like longer term. What about our cardiovascular health as we get in our 50s, 60s, 70s? Um, this manifestation of high glucose driving up with high insulin it's going to wreak havoc on the cardiovascular system. And A1C can look normal. I would say I've talked with a lot of women in this program, and maybe their primary care office is checking their A1C once a year, and they've been teetering in this pre-diabetic territory. They're right on the cusp, and or they're right under, and no one's really concerned until you're fully, diabetic. My thought on this is having a more stable A1C over the course of the year is going to help with just inflammation. It's going to help with body composition. Um, so, looking at the optimal ranges is something that we're a big advocate of, and being able to keep that within range through lifestyle, nutrition, supplementation, and then for some individuals who do have diabetes, there's pharmaceutical intervention that people can use in place to lower the A1C. So it's a tried and true metric. I think it provides a lot of information, but it's not as helpful without your fasting insulin. Um, so some of the things that you'll see in regards to, let me see what slide it's on. Yes, I'm glad it's next. Fasting glucose. So a lot of times your fasting insulin may be high in the background, and that's pulling down your glucose. And the way I describe this is if you've ever met a diabetic, their blood sugar is quite high. They have to take insulin to bring that down. A lot of times, if you're just doing labs through your primary care office and they're looking at your glucose, it may be within range. And that range goes from 70 to I think 99. So say you're at a 98, but no one's ever looking at your insulin and your insulin's a 20, and that's the reason your glucose is being pulled down. Eventually, over time, that pancreas gets fatigued and worn out, beta cells quit working, and then your glucose shoots up high, and then one day hey, you're diabetic. So the glucose is helpful, but you want to look at that in the lens of your A1C and your insulin. So blood sugar is a single moment in time. A lot of things can influence this, like not fasting. So I always recommend fasting for 12 hours when you're doing your labs. Um, Elevations in glucose does increase oxidative stress. And that can cause issues on the kidneys. It can drive up blood pressure. It's not just a carbohydrate thing. Sometimes this can be other inflammatory issues in the body. This could be poor circadian rhythm. And then GI function. All of those things will play into your glucose, and over time, those things can create that dysfunction. Um, so yeah, it worsens insulin resistance over time. And just because you're within range, if you're not looking at these other markers, um, you may not be able to catch insulin resistance, uh, glucose disturbances till it's already manifested into a further disease state. So looking these in conjunction is quite helpful. Next would be triglycerides. I would say a lot of times this will also bleed into the glucose, insulin, A1C. So why they matter, they're going to reflect liver fat. So triglycerides are made through something called de novo lipogenesis. It's a fancy term of basically taking carbohydrate converting it into fat. Triglycerides elevate when the liver becomes insulin resistant. So the liver can hold, I don't remember the exact, I think it's like 5 grams of glucose, as your muscle cells can hold 2 or 3 times the amount of that. So if someone is insulin resistant, a lot of times that liver will become insulin resistant, and then that will start to drive up triglycerides. So we see that commonly in metabolic syndrome. So if you have high glucose, high A1C, high insulin, a lot of times that triglycerides also going to be elevated. Patterns to watch, high triglycerides, low HDL, those are your quote unquote good cholesterol. We see that a lot of times in um, inflammation or inflammatory states and metabolic distress. In ALT, AST, these are liver enzymes. Most people are getting these looked at. And the interesting thing with the ALT and AST, they may not always reflect on paper that there is dysfunction at the liver. A lot of times they do, but sometimes it could be they're not actually elevated, but the liver is still stressed out. Um, Basically, the liver is going to be one of the organs that have a lot of mitochondria associated with it. The liver has a lot of different processes from making antioxidants to metabolizing cholesterol to processing hormones. So, if you've worked through this program, we've probably talked about this 100 times, but liver function is very important. It's something that we look at and do a lot of lifestyle supplements and interventions to help with the function of the liver. Homocysteine, this is one of my favorite markers. Why I like to look at this is I actually have a genetic issue where I express a lot of homocysteine or build it up in my blood. And it's an has a lot to do with methylation and oxidative stress or inflammation. So elevated levels can lead to damaged blood vessels and dysfunctional mitochondria. It's an increased cardiovascular and cognitive risk. So it creates uh, vascular inflammation, specifically in the brain. Um, it high homocysteine often signals it can be a couple things. So right here on the right hand side, I wanted to show the methionine cycle. So protein feeds into this. So
You're not
one of
recognizer.
the
Accept the license agreement.
big things is going to be having adequate protein. When we look at that, the other component is being able to digest protein. I'm sure Ashley could go into a long spiel about that. Uh, but so your protein consumption matters. Your gut health is also going to matter in that. You're going to need enough stomach acid to be able to break down and extract those B vitamins. You also need vitamin B6. This is another unsung hero in this process. And then methylfolate. Some of us genetically need more methylfolate. I take a over-the-counter supplement. I think it's 300 times the daily recommendation of traditional methylfolate, just due to me having a really high homocysteine. Some of the things that you could see with that is impaired detoxification. So I will often look at that with hormone statuses like estradiol or estrone, um, and then chronic inflammation. So the other interesting piece is all of your neurotransmitters like dopamine and serotonin, they're all going to metabolize through a different byproduct of homocysteine. So it can also influence mood stability, anxiety, depression. So there's a lot of different buckets that homocysteine can impact, and I think it's a valuable marker to look at, especially when we're trying to figure out hormonal symphony. And I believe that's all of the specific things on the deck here. Let me do this. Boom. I wanted to stop the slides and answer any questions. I know I have a couple new names in here um, that potentially are new to the program. I wanted to see if any existing or any new clients had any questions, or if any of the coaches had any questions or any input on the things we covered here. Maybe not.
I had a question. I don't know if this is something that you've ever covered before, relating to inflammation and Hashimoto's. I had heard that some people were using a microdose of GLP-1s, like not the standard dose that someone would normally take, but just a microdose to help with inflammation and Hashimoto's. I just wondered, is that a thing? Is that real?
Yeah. I've heard people looking at GLP-1s to manage all sorts of inflammatory issues. Some of the interesting things with specifically, they're probably referencing trizepatide, which is the dual agonist, not semaglutide. That would be your Ozempics. That glucagon agonism from the trizepatide is pretty helpful at improving glucose utilization, and that is a component of reducing inflammation. I would say that that wouldn't be my first step with Hashimoto's. A lot of times with the overactive immune function, I like to look at things like low-dose naltrexone. I don't know if anybody's ever talked to you about that or you've looked at any information on that. Both of them can have utility. The thing I like about low-dose naltrexone is it's going to modulate the immune system. You have a adaptive and innate immune function, and it's kind of like this seesaw, and it can go up and down. You have your innate, which you were born with, and then your adaptive, which you acquire from being exposed to different pathogens. A lot of times, what happens with that seesaw is that the innate immune system will take over, and that's where your body starts attacking its own tissues, which you see in Hashimoto's. What low-dose naltrexone does, it works off of opioid receptors in the brain, and that's one of the reasons that it will kind of balance that seesaw. It also modulates T cells. You have different T cells. This basically helps your body shift into a less inflammatory process when reducing T cells or making T cells. Both will work. I just think that a lot of times with Hashimoto's, I also see a lot of GI issues present. It may not be your case, but I do see GI being an issue for a lot of Hashimoto's. If we're already having GI issues and then we bring in something that slows down digestion, potentially could cause other issues. I would say that if you're looking at the GLP-1s, the trizepatide is probably safer than some of the newer. You'll see retatrutide is the triple agonist that's coming out. If your body's already inflamed and you already have issues with your mitochondria and you try to use something like a retatrutide to enhance those processes, a lot of times, if that machinery is already broken, it's going to create more inflammation. So I would say it could work. I would just be cautious. And then usually the microdosing, traditional dose with trizepatide is about 2.5 milligrams. A lot of times I see clinics doing like 1.25 milligrams. It potentially could work for people. My big thing is kind of looking at the bigger picture and making sure you have your ducks in a row from like a digestive standpoint before bringing it in.
Okay, gotcha.
Um, in regards to the Hashimoto's component, like the interesting piece with that, it's I think so many people are obsessed with looking at the function of the thyroid gland, but you have those buckets, if you will, of digestive health, stress and adrenal balance, mitochondrial function. I think I'd like to look at all of those layers before just bringing in a GLP. I know it's not as quick and easy, but I think that you'd probably be doing a better service to yourself if you had Hashimoto's and you were trying to reduce inflammation, is kind of looking at those other buckets and seeing which one you could kind of fill up and work on prior to just using a GLP.
Got it. Okay.
Great question, though. Do we have any other questions? It could really be about anything. It doesn't have to be on the topic of inflammation.
I have a question, Justin. How dangerous is high ApoB?
Yeah, that's a good question. I do think that um, there is more that goes into ApoB than just so ApoB can be problematic. Say that you have a lot of inflammation in the cardiovascular system. So uh, you want to think about high glucose, high insulin, high A1C, high C-reactive protein, basically creating micro traumas in the cardiovascular system. So they're going to create cracks and gouges. LDL comes out to basically heal that or basically plaster those cracks and gouges. Um, if someone doesn't have a lot of inflammation issues and they have a higher ApoB, I would probably look at a CT scan, see what calcification is in the arteries. If it's low in someone, probably less of a concern. I would just do the due diligence of doing some like cardiac screening if someone has a really high ApoB because it could be problematic. So it's a context dependent on the individual. I think the other thing is a lot of people don't want to use a statin when they um, potentially have high cholesterol or high ApoB, and that's like a first line defense a lot of times through your PCP or your cardiologist. I know not everybody has the means for it, but there are other drugs. Dr. Peter Attia, he's one of my favorite cardiologists to look at. He recommends a drug called Prolont, or it's a PCSK9 inhibitor, and they're a lot more tolerated. So, say someone does have plaque and they're wanting to lower LDLs, ApoBs, I would probably look at a PCSK9 inhibitor versus using a traditional statin. But it ultimately comes down to how much plaque is present when you're doing imaging.
Thanks. Would you recommend the Clearly test, Cleerly? It's read by AI and it looks at all the arteries and the plaque, can see the plaque in the arteries.
So
At
you and I were talking about that. I have a client in Canada and she does, let me get the name of this test. It does more than just the arteries. It's a full body scan. It also will look at tumors potentially. It'll also look at if people have like an aneurysm that's dormant. Let me find the name of this test. I'm sure that one's fine. The only one I've ever really looked at is going to be a, bear with me.
and does taking estrogen, testosterone, and progesterone potentially reduce the ApoB?
Estradiol can in
Estradiol?
postmenopausal scenario, and testosterone can be beneficial for the lipids unless it's too high. And I see that a lot in men. Men tend to overdo testosterone, and it will suppress HDL proteins and drive up LDL. So you want to get it to a therapeutic number, and that's going to be depending on where symptoms are relieved, but I would say women probably don't need a testosterone of 4 or 500. Your range for postmenopause, I think, goes up to like 60. I would say somewhere 60 to 100 is probably a good range. I've seen prescribers go much higher, but I see that it could potentially cause more issues with cardiovascular function. High blood pressure is the other component you want to be careful with in regards to. Um, high cholesterol.
Yeah, I'm 20 years postmenopausal. I have basically no estrogen, no testosterone, nothing. So I've been taking it now 2 months. I'm going to get my blood done this month and we'll see what happens.
Yeah, the thing I would say is making sure your testing is correct. So catching it at the low end. So if say you're doing your hormones twice a week, if you're doing an injection, going in the morning prior to one of your injections. So say Tuesday, Thursday, do it Thursday prior to getting your labs draw so you can catch it at that low end. What you don't want to do is dose it and then walk in and get your labs pulled because it's going to be high. It's going to create a false elevation in your numbers.
Okay. What is
Um,
your process about LP little a?
LP little a is a genetic marker. Not many things bring it down. I think aurivastatin can bring it down a little bit, but that's going to be more of a hereditary thing. That's where like you'll see like triple therapies. So you'll use a cholesterol inhibiting medication like ezetimibe, may use a statin like aurivastatin, then like a PCSK9 inhibitor. That may modestly reduce it, but a lot of times that's going to be elevated from genetic. Let me find this, and I want to tell you the name of this. Um, this is called, let me see. Um, I wish I could share this, but it has all of her information. I'm trying to get the name of the test. but it'll show fat deposits on the liver. It'll show any cysts. It'll show any issues with uh, bone mineral density. Prenuvo, that's the name of the scan. I don't know. I think the Kardashians were the ones who were really big in the Prenuvo when it first came out. I think a lot of people are aware of that. But that will show when I look at this specific, uh, it's an MRI screening, and it's going to pull brain, sinus, thyroid, cervical lymph node chain, lungs, heart, greater vessels, breast, esophagus, stomach, liver, gallbladder, biliary system, pancreas, spleen, kidneys, adrenals, bowel, uterus, ovaries, spine. So there's quite a bit of things, even into joints. So it'll show shoulders, pelvic, hips, knees, ankles. It is quite expensive. And I believe that there's probably, you're somewhere in the Northeast. Is that correct, Lisa?
West Michigan.
You're in
Well,
Michigan.
kind of like the gallery test, which does all that, the similar.
Yeah, I would say probably pretty comparable.
Mhm.
Um, I don't know if the gallery does any brain imaging. It may.
It
Uh,
does
it does
bring
it.
it. Mhm.
Yeah. There's different places. They went to Denver to do these. I know there's one in Toronto, but I think they're listed all over. I was looking at this for my dad, and I know we're in Arkansas. I knew there was a location in Dallas, so I'm pretty sure you can pop up and do them in various places. They are pretty expensive, though. You're probably $2,000 to $3,000 to do that, but if you have the means for it and you want to be proactive with your health, it's something that I would like to do. I just don't have the funds right now to spend $3,000 to do a full
I
body.
have the funds. I'm just not sure I want to see the results.
Yeah.
That's
Yeah, I would say it's um, probably worthwhile, especially if cholesterol is an issue and you're getting a lot of pressure from cardiologists or PCP to use a statin or something like that. I would think it would be worthwhile to at least have some of those.
pressure for 30 years. I haven't folded yet, so.
Yeah. Yeah, but what I would say is looking at your labs. I know that we had talked about doing some specific things for your cholesterol from a natural standpoint, optimizing thyroid, several things. So it'll be interesting to see. I think with poor or basically no adrenal output, that's something that's also going to play a role in that. So you got a couple different moving pieces that can impact all of those systems.
I don't think anybody really knows exactly how the no adrenal function works with that.
I would agree with you. It makes it super interesting. Um, it's a lot of things with the hypothyroidism. Are you using uh, what are you using from are you using hydrocortisone or are you using
Using prednisone,
prednisone? Yeah.
recortisone.
Yeah, so
Yeah.
it's I think that can throw some wrenches just in like metabolic function as a whole. It's also going to impact liver and glucagon and cortisol. So it's hard to say.
It's a
Uh,
big mess.
it's a lot of moving
Yeah.
pieces.
Oh, well. I'm working on it, so,
Yeah, that's all you can do.
right. Well, thank you.
Absolutely. Do we have any other questions?
Hi, Justin. I'm just wondering, you mentioned about statins earlier. What do you find um, is the major problems with a low dose statin?
Um, the thing that I'm like most curious about with statins is they stop cholesterol synthesis at the liver. Cholesterol is an essential thing. Your brain's made up of primarily fat and cholesterol. So I would be worried long term about cognitive health. I know a lot of the traditional data is given to prevent Alzheimer's and dementia. Um, I'm kind of on the fence with that. I think a lot of people in functional medicine uh, have speculations about that. And the other piece is like if you're looking at even cellular production of energy in the mitochondria, mitochondria is 70% protein, the rest is fat. So you want to think about your lipids have a lot to do with the bilayers of the mitochondria. So taking a statin and stopping cholesterol, I think could be problematic. I think it can be problematic for those who still rely on their own hormones as well. If you think about the origin of all your sex hormones, they come from cholesterol. So if you're stopping the production of cholesterol, you may have issues making things like testosterone, estrogen, cortisol, the whole gamut of sex hormones. So, I think that what I've seen with other people is the statins maybe can address some of that issue, but we also need to look at the liver. Is there any issues with bile flow? Is there any issues with hypothyroidism? I think there's several systems that go into that, and it's just not excess cholesterol. So it's not necessarily that I'm against them. I just think that a lot of times they're given and there's no other workup given to that person outside of the statin. Is there's a lot of things that can tie into that. The other piece with it is I do think they're valuable if someone does have, they have 70% blockage of an artery, then you probably need a statin. I think arovastatin is one of the only drugs that is shown to reduce plaque buildup. So, if it's have a heart attack or take a statin, I'm taking a statin. But that's where it goes back to my conversation with Lisa. You may want to do some imaging prior to see if you're at risk for that versus just taking a statin.
Mhm. And that Dr. Peter Attia recommended drug, I forget what you call what the name is that you mentioned. How does that drug operate to reduce someone's cholesterol?
Yeah, I'll drop it in here. So PCSK9 inhibitor. PCSK9 inhibitors lower PCSK9 at the liver. All cholesterol is made and housed in the liver. I believe like 25 or 35% of cholesterol comes from food. So a lot of times people can over absorb that from food, but a lot of times I see people having issues just regulating cholesterol at the liver. Again, that could be a bile issue. Fiber is going to play a role in that. Also, GI health is going to be another area what can drive up cholesterol. But yeah, the PCSK9 inhibitors, they're I think a twice a month injection, but I don't believe traditional like insurance covers those. My client in Canada pays out of pocket for her Prolent injection. And I think it's like $600 a month. So that may be nothing to some people, but to some people, that's a lot of money. But it may be worth it if somebody has the means for it and is already on a statin.
And with the gut, is it like gut dysbiosis or gut immunity issue, or what is usually correlative with the high cholesterol and the gut
I,
microbiome issues?
I would probably tag Ashley and she'd probably go a lot further on that on me. I'm under the impression lipopolysaccharides, so the endotoxins from the dysbiosis can drive up LDL. LDL is an immune response, but Ashley, if you don't mind, maybe you could go a little bit deeper on that.
Yeah, I can try. Um, so yeah, I mean the gut, gut can influence everything, but specifically cholesterol for sure. That when you have if you have dysbiosis, so an imbalance of that bacteria, it can impact how well you excrete bile, essentially. So it can increase that bile reabsorption and can kind of trigger the liver to make more cholesterol. And so that can result in a higher LDL. Um, Low fiber can also impact that. Because the good bacteria need that fiber to create short chain fatty acids and butyrate and stuff like that. Um, it can, when that's, when you don't have enough of the short chain fatty acids, it can impact the cholesterol synthesis in the liver and how that does that. Also, I think this is what you just said, but endotoxins also, just like with the inflammation. And so that can definitely impact that because it can produce lipopolysaccharides. So that often can make leaky gut, creates low-grade inflammation, and consequently that impacts lipid metabolism and LDL production. So hopefully that kind of answers some of that. I mean, and the last piece of that would really just be like, I know you talked about this earlier, but like when it's related to the gut, the insulin resistance, that insulin signaling can impact the liver and consequently the LDL cholesterol rising. So, I mean, there's a lot of kind of different avenues of how it can influence that. I would say ultimately, in general, and I say this, like test the gut first because an imbalance of gut can just have such a ripple effect in so many different, I guess, avenues. I mean, hopefully that helps.
Yeah, no, that's very helpful. And I don't know if anyone has any other questions. I have more questions. But anyone else that has questions can go ahead.
Go ahead, go for it.
Oh, okay. You were saying earlier, Justin, about sometimes ALT markers and the traditional markers for liver disease don't pop up, but someone still has liver issues. What are some of the, when you do more in-depth testing, what are some of the tests that are useful to determine whether one has liver disease, even though the ALT and everything looks good?
GGT is helpful. That has a lot to do with bile duct obstruction. I also want to look at LDL. I think LDL is a really good, triglycerides are really good to look at. If you have issues with bile duct and those things clog up, cholesterol is going to hold more fat. And then over time, you could develop fatty liver. I also want to look at thyroid function. A lot of your thyroid hormones like T4 into T3 convert at the liver. I want to look at your homocysteine. Homocysteine is going to reduce down and make cysteine, which is a precursor for glutathione that's made from the liver. Uh, Estrogen metabolism, the conversion of um, some of your water soluble forms of estrogen are going to break down at the liver. So if someone has more estrone and less estradiol or a disproportion of that, or if we do a Dutch test and look at that, those are all things that potentially could show that the liver is under struggle. And what I would say a lot of times is the ALT and AST, they can elevate and then go back to normal. They're very transient. They move up and down throughout the day, throughout the week. It's kind of based off of what you're exposed to. Like if you hypothetically took an ibuprofen and drank 3 beers, your ALT and AST are probably going to be high. But if you have low grade inflammation and issues with cholesterol, it may stay at high normal, and then that's going to slowly compound over time. So a lot of systems will tie into the liver. So I like to look at it more as like a global picture.
Okay, that's great. Sorry, I have another question.
Yeah.
I was listening to the audiobook Unbreakable by Dr. Vonda Wright, and she highly recommended a test, apolipoprotein little a.
Hmm.
And I just wondered because I did a bunch of tests, including the ApoB, but I have never done the Apo little a. Do you find that that's an important test?
I would screen for it just to see if you have that genetic component. Me and Lisa were talking about that. You could pull that test and look at it and see if you have elevations to lipoprotein little a. A lot of times that's going to be that genetic marker, though. I think it's worthwhile. It's kind of like pulling thyroid antibodies. If you've never done it, you should at least screen it and look at it because I've met a lot of women in this program who had no idea they had high thyroid antibodies until we did a test in their 40s and it's caused a bunch of issues for them. So I think just screening things and being proactive is helpful.
Oh, okay, so it screens for thyroid antibodies because Dr. Vonda Wright's book was kind of over my head. Her explanation, chemical explanation was over my head. So that's
N-
what it is.
No, I'm sorry. I was
No.
just giving a comparison. It's for
Oh,
cholesterol specifically. Lipoprotein little a is uh,
oh,
a different form of lipid. I don't know the exact metabolism of
okay,
lipoprotein delay. That's something I'd have to look at.
okay, okay. Thank you.
Absolutely. I'm happy to answer any more. I don't think we have any other questions. So if you have any other ones, we're happy to answer it.
I'm full of questions. I think the more audiobooks I listen to, the more the more I have questions. Do you find that people with um, hypothyroidism, that often there's a linkage between that and or sort of imbalanced microbiome or gut immunity or gut dysbiosis? Is that, and if they can deal with the gut, they can cure their hypothyroidism, or are they kind of stuck on the pharmaceuticals for life? How do you find that?
I think it depends, but a lot of the T4 to T3 also converts in the GI tract, and you have a lot of thyroid receptors in the digestive tract. So yeah, I think that I was talking with Gloria about Hashimoto's and how GI can tend to be a piece of that. So yeah, I would say potentially someone could improve thyroid function. It just depends on how severe the hypothyroidism is. Say somebody is slightly abnormal or sluggish and have symptoms, I think addressing the gut's a great way to see if you can alleviate and improve some of those metrics. I think it just depends. Say someone has a TSH of 20 and they've been, hypothyroid for a long time. It may be really hard to just fix the gut and make that better. But if someone is right on the cusp, it could be a contributing factor. I think adrenals are also a really big contributing factor of thyroid function.
If I can jump in there a little bit too, I think that there's so much just immune system regulation with your gut that healing your gut in general, it just like gives you so much more of a fighting chance against I'll say autoimmunity in general. But I mean specifically in the thyroid. So like that, you don't have as many like T cells when you have dysbiosis, and so just that your immune system can kind of be trained. And so I think that gives you a fighting chance in that way. The other thing is just absorption. So, like when you have the imbalance in the gut, you're potentially not absorbing a lot of the nutrients that help regulate your thyroid health. So, I mean, that just on a kind of basic level, it, again, just gives you a better fighting chance against your thyroid, being happy and the conversion of T4 and T3, and there's another piece of it just that happens in the gut. So anyway, it can help, like, even if it doesn't cure it necessarily, you can reduce your antibodies, you can help your immune system, you can improve the conversion, um, anyway, and improve symptoms of it as well.
Make your medication more effective if you address the gut. That goes back to that absorption piece. So I think it's important to at least consider in the big picture of hypothyroidism.
Okay. Back to what you're saying before about that PCSK9 inhibitor, how does that function on a chemical level to deal with the cholesterol?
It lowers PCSK9 at the liver.
Okay. And sorry, what is that? I don't know. I
That
don't
stops
understand.
some of the production of cholesterol.
Oh, wow. Oh, okay. Hmm. You wonder why that isn't the common cholesterol drug and not a statin. That's really interesting.
Because statins are a penny to make and PCSK9 inhibitors are several $100s to make.
Ah, okay.
Yeah,
Okay.
if you look at most common drugs prescribed like globally, statins are number one. It's just affordability and availability. They're everywhere.
Hmm. Okay. Okay, one last question. If nobody has any more
Yeah.
questions. Okay, if someone's prolactin normalizes and repeat blood work shows that on the critical days it's within the normal range, is a P5P supplement still useful to take, or is that only if you have actual high prolactin?
Yeah, P5P is vitamin B6. It's still quite helpful to take. It goes back
Okay.
to the homocysteine slide I was showing. P5P helps reduce homocysteine and make glutathione. So all your B vitamins are essential. Some of us just need more than others. So I think taking an active B6 is great. I take one every single day.
Oh, okay. Okay. Hmm.
Well, great. I appreciate all the questions.
Oh my God, I feel like I'm just hogging
No.
the whole call. Just one more question. For
Uh,
vitamin D, um, if like what is what would be a recommendable daily dose? I know I used to take 4 or 5,000 IUs a day for years. And then I was in the toxicity levels for vitamin D. So I've taken a break from vitamin D for 4 months. What would be like a safe dose to take now
Or
that it's cleared from my system? Like 2,000 IUs, is that good enough? Or
I think it depends on where it's at on paper. So the way I look at it and rationalize it is, say somebody comes in and they have a vitamin D of 10. I may say, hey,
right,
let's take 10,000 IUs. Say somebody has a 60 or 70, maybe a
right.
thousand IUs with K2. You may not need that much to maintain that status. It also depends on where you are globally. Also depends on
Mhm.
the time of the year, and then how well you
Oh,
absorb it from the sun. So I
oh,
think
wow.
there's a couple things that tie into that. Um,
Okay.
I think the absorption from the sun is an interesting component because I've met some women here who live in Florida and have a bottomed out vitamin D, and they swear they're outside in the sun all the time. And then I meet people, somewhere higher up in the United States, and their vitamin D is maybe not in a sufficient range, but it's not deficient. So I think we all absorb it at different rates. And I don't know if there's a test out for that yet, but I would love to know if there was, because that's one I would do and recommend to people.
Right.
One of the things that I do, I mean, I guess it depends on how often you do blood work, but what I've done with clients is, so let's just say you went and had blood work drawn tomorrow, and and your vitamin D was low. If you haven't been taking any, then maybe start with anywhere between 1 and 3,000 IU's, right? And then you take it for a while, and then I don't know, a few months later you test it, and if it's like off the charts, then 1,000 or less is good. So I mean, sometimes you can just do it based off of testing to see where you are and kind of find your maintenance dose. Again, kind of like Justin said, if somebody's really low, I might take them high to kind of build them up and then lower it for a maintenance dose later. If you're able to, get that testing done, and even just testing that by itself is a pretty cheap test. So you could just test a vitamin D if you wanted to and kind of find your maintenance dose that way.
Okay, awesome. Thanks, Ash.
All right, we got time for one more if anybody else has a question.
Hi, Justin. It's Julie. Hi, Ashley. Very new, but I wanted to go back to the hypothyroidism or the thyroid. And it sounds like many people are on thyroid meds, and I'll raise my hand as a Synthroid. Um, is it potentially possible, like, get yourself straightened out or in a healthier mode that you can come off of, the thyroid prescription meds, doing other things, or I think we all hear it's, a life sentence, with it. But I don't feel like it's doing anything, but I don't know, obviously, because I'm not medical, but just the possibility of coming off of that. Do people in the program, or maybe come off of thyroid meds because you really don't need them because you have your TSH system working, more properly?
Yeah, I think it depends. We want to acknowledge all those other systems. So that could be gut, that could be liver, that
Hmm.
could be nutrient status, that could be adrenals. I think working all those systems, and if somebody wanted to come off of the medication, you could let your TSH normalize and see how you feel and look at that. So I don't think it's not a possibility. I think it just depends on the severity of hypothyroidism. The one thing I will tell you is I don't think that Synthroid is the best choice of medication for hypothyroidism, though. You're not feeling that because your body is already in a position where it can't convert T4 into T3. So
Hmm.
why do they give you more T4? Your body's not going to do anything with it. I would say pretty much everybody who comes in on Synthroid doesn't really feel a ton of benefits. A lot of times, armor thyroid or dual thyroid, a T4, T3, or a T3 only, it just depends on the person. But
Right.
having some active T3 in your system, that's what's going to drive up energy, metabolism, body temperature, fix brain fog, help with digestion. So I do think that if somebody's saying their Synthroid's not working, I would agree with them and say that's probably not doing much for you, and you probably need to look at other options of thyroid. And if somebody wanted to come off of that, they could come off and see how they feel. They could retest it And if it doesn't get better, they could look at a dual therapy, and that may be the best bet for someone.
Interesting. Good. So it's a matter of knowing, because I'm obviously so new, so I'll be doing some blood work here very, very soon. So, all right, great. Thank you.
Yep, don't take your Synthroid before you test because your TSH will be
Right.
suppressed.
Well, that's that I had that question, but I was actually just going to send a message over to Ashley about it says supplements. So anything that's outside of, but what about the prescriptions? Are you talking about those supplements also? Like I have to take two meds because I had an aortic aneurysm for open heart surgery. So there's two meds that I've had to take for 4 years now. So it's stopping everything
I
before you
would
go and give.
I would pull all your nutraceuticals, any vitamins or minerals. I usually do the pharmaceuticals, skip the morning of, take it right after. I would do your labs in the morning, but if you're taking specific medications, I'd take it the day prior, and then the morning of, I'd try to
Okay.
schedule early, do it, and then I usually just have my meds in the car because I do take thyroid meds,
Yeah.
and then I'll take that.
Okay. All right, cool. I didn't even think about that, like just the timing of it. 'Cause it's not like it's every day at 6 a.m. anyway.
Yeah.
Trying to time the cat gets up at 4:30, then I'm up at 4:30, or it might not be till 8 or 9 till I get to it. So that would be a great idea.
Having
Cool.
a good close to 24-hour window. A lot of times endocrinologist or PCP doesn't tell you anything, and you dose your thyroid
Right.
and you come in and your TSH is in a great range, and they don't look at your T3 and they're like, oh, you're good to go, let's maintain that
Right.
dosing. So it's good to at least see it on different spectrums. So hey, here it is while I dose it in the morning, here it is when I go 24 hours. What are my symptoms? I think labs can be interpreted a lot of different ways, so you having more than just one way is going to provide more insight on symptoms, because that's ultimately what with like thyroid medication, we also want to relieve symptoms, not just suppress your TSH.
Right. Right. Yeah, it's interesting you talk about that range. I felt like that cartoon Kilroy, like I'm hanging on to the lower rung of the range, but you're still in range, so you're good. I was like, yeah, I don't feel good though.
Yeah,
So yeah, interesting.
yeah,
Appreciate it.
it'll be good to look at all that and then just have a different perspective on it. So I'm looking
Hmm.
forward to that.
Cool.
All right, everybody. Well, I appreciate the questions and the conversation. I will send this over so it gets loaded up, and I hope everybody has a great rest of their week.
Thank you.
Thank
Bye.
you. Bye.
Thank you very much. Bye-bye.